NSAID মানে Non-steroidal anti-inflammatory drug. মার্কেটে প্রচুর পেন কিলার নামে ওষুধটা পাওয়া যায়, but these are not just painkiller because their action is to inhibit pain, inflammation, that means swelling, pain, redness, in different measures. A variety of drugs are available among the non-steroidal anti-inflammatory drugs, and their potency as antipyretic, as analgesic, as anti-inflammatory differs among different drugs. Unlike morphine or other opioids, they also decrease pain. But what are the added advantage of NSAID? They do not depress central nervous system. Sedation effect are nahi. They do not produce physical dependence, and they have no abuse liability, unlike opioid-like drugs. And they are effective in inflammatory pain, which are not shown by opioid-like drugs. They are also called non-narcotic, non-opioid, or aspirin-like analgesics. Aspirin is a prototype drug among the NSAID. How are they acting? They are acting by on the peripheral pain mechanism, primarily on the peripheral pain mechanism, but they also act on the central nervous system to raise the pain threshold. They are most commonly employed as over-the-counter drug, particularly aspirin and paracetamol. Now, how does the non-steroidal anti-inflammatory drugs act? They basically inhibit cyclooxygenase enzyme. We all know that the cellular membrane, they are metabolized by phospholipase A enzyme to arachidonic acid, which are acted upon by two enzymes. One is cyclooxygenase, which help in the synthesis of prostaglandins, and one is lipooxygenase, which help in the synthesis of leukotrienes. Now, these NSAIDs, they are inhibiting cyclooxygenase enzyme. Now, among the cyclooxygenase enzyme, there are two variants, cyclooxygenase 1 and cyclooxygenase 2, COX1 and COX2. COX1 is normally present in the human body, in the brain, in the platelet, in the endothelial cells, in the stomach. And COX2 is an inducible enzyme. COX1 is constitutive enzyme or the housekeeping enzyme. COX2 is inducible enzyme, which is induced, whose synthesis is induced in the presence of inflammation. Although a small quantity of COX2 enzyme is also present in the gastric tissue in the brain. So, among the non-steroidal anti-inflammatory drugs, we divide them into different groups, particularly non-selective COX inhibitors and the selective COX inhibitors. Non-selective COX inhibitors means they inhibit both COX1 and COX2 enzymes. Non-selective COX inhibitors, they include salicylates, that include aspirin, is a prototype drug, propionic acid derivative, ibuprofen, naproxen, ketoprofen, carbiprofen. Phenamides, they include mefenamic acid. Enolic acid derivative, they include piroxicum, tenoxicum. Acetic acid derivative, they include ketorolac, indomethacin, nabumeton. Pyrazolone derivative, phenylbutazone, oxyphenbutazone. Preferential COX2 inhibitors. Of the COX1, they preferentially inhibit COX enzyme. They preferentially inhibit COX2 enzymes. Include nimesulide, diclofenac, aceclofenac, meloxicam, etodolac. Some selective COX2 inhibitors are there. Celecoxib, etoricoxib, parecoxib, that means they inhibit only the COX2 enzyme. And they are analgesic, antipyretic with minimal anti-inflammatory action, that particularly include paracetamol, and lefopam is also there. Now coming to the mechanism of action. Primarily they inhibit COX enzyme, and so they inhibit the synthesis of prostaglandins, and that is the main cause of their analgesic anti-inflammatory action. Now COX enzyme, They exist in these are flow chart showing membrane phospholipid, phospholipase A, arachidonic acid, and cyclooxygenase. They are helping in the formation of prostaglandins, and the lipooxygenase enzyme, they are helping in the synthesis of leukotrienes. Now COX enzyme, they exist in two isoforms: COX1, that is constitutive COX1, and or the housekeeping enzyme, and the inducible COX2, that whose synthesis is induced in the presence of inflammation. COX2 is present in minute quantities in brain, juxtaglomerular cells of the kidney, and in the fetus. Most non-steroidal anti-inflammatory drugs, they inhibit both COX1 and COX2, except some selective COX2 inhibitors which are available. They inhibit the enzyme reversibly. They cause reversible competitive inhibition of the COX enzyme, except aspirin, which irreversibly inhibits the enzyme. Why? Aspirin, chemical name is acetyl salicylic acid. It has got acetyl radical. It uses its radical to acetylate the serine residue of the COX enzyme, and thus irreversibly inhibit it. Now, effect of this prostaglandin synthesis inhibition. Okay, first is analgesia. So, how the non-steroidal anti-inflammatory drug is causing analgesia? By inhibiting the peripheral pain receptors. NSAIDs block the pain sensitizing mechanism induced by bradykinin, interleukins, and TNF alpha, primarily by inhibiting COX2 enzyme, more effective against inflammation associated pain. Central component of a central pain suppressing component is also seen, where they increase the threshold of the pain. Antipyretic. Basically in the hypothalamus, due to the production of the prostaglandin E2, the temperature threshold is raised. Now what happens? These NSAIDs block the action of pyrogens and inhibit the synthesis of prostaglandin there in the hypothalamus, and thus they are decreasing the threshold of the temperature and causing decrease in the temperature, but it does not decrease the temperature in the normothermic individual. Again, a COX3 enzyme has been isolated in the dog brain, and paracetamol is found to inhibit that enzyme. So paracetamol or acetaminophen, it has got additional effect of inhibiting the synthesis of COX3 enzyme. Anti-inflammatory action by the inhibition of COX2 enzyme at the inflammatory site. Now, most NSAIDs, they show the potency of the different NSAIDs differ in their anti-inflammatory action as per their role of their potency of inhibiting COX enzyme, except nimesulide, which is a potent anti-inflammatory drug but weak COX inhibitor, because it shows anti-inflammatory action because of other effects, like inhibition of expression activity of adhesion molecules. Certain NSAIDs, they show additional effect as anti-inflammatory action, like inhibition of expression activity of adhesion molecules, like ELM1, endothelial leukocyte adhesion molecule 1, ICAM1, that is intercellular adhesion molecule 1. Then inhibition of expression of selectins and integrins on the inflammatory cells, the inhibition of generation of superoxide and free radicals. These are certain other mechanisms by which the NSAIDs are showing anti-inflammatory activity. And they also affect growth factors like GM-CSF, IL-6, as well as lymphocyte transformation factor. They also cause stabilization of lysosomal membrane of leukocytes and antagonism of certain action of kinase. These are certain mechanisms by which they are showing anti-inflammatory action. But the primary role is inhibition of COX2 enzyme. Dysmenorrhea. It has been found that in dysmenoric individual, the uterine prostaglandin level is high, and the use of NSAID is effective in 60 to 70% of the individual. Anti-platelet aggregatory action. We know platelet, they produce thromboxane A2 and that is responsible for platelet aggregation. Now, thromboxane A2 is generated by cyclooxygenase enzyme, and so by inhibiting cyclooxygenase enzyme 1 in the platelet, basically NSAID, they show anti-platelet action. In fact, low dose aspirin is a drug of choice in patients with cardiovascular disease. This is because of this anti-platelet aggregatory action. Again, the prostacyclin is synthesized by the endothelial cells. Endothelial cells because of COX2 enzymes. Now, these enzymes are also blocking that. So, prostacyclin is anti-aggregatory. So, it is also inhibiting prostaglandin I2 secretion. It is also inhibiting thromboxane A2 secretion. But the effect on thromboxane A2 is larger. So, largely NSAID, they show anti-platelet aggregatory action and thus they prolong bleeding time. Ductus arteriosus closure. It has been seen that in the newborn infant having patent ductus arteriosus, the prostaglandin concentration is high there, and the short-term use of NSAID, particularly aspirin and indomethacin, they causes closure of the ductus arteriosus. But again, in the late-term pregnancy, the use of NSAID that can cause patent ductus arteriosus, that is called premature, that causes premature closure of ductus arteriosus. So NSAID should be avoided in the late-term pregnancy. Risk of postpartum hemorrhage is also increased because of increase in bleeding time. Parturition. NSAID have the potential to delay or retard labor. However, labor may occur even in the absence of prostaglandin. Gastric mucosal damage. Non-steroidal anti-inflammatory drugs, they are ulcerogenic. They cause inflammation, gastric inflammation and ulceration. How? This is because of the inhibition of COX1 enzyme in the gastric mucosal cells. That causes inhibition of the gastroprotective prostaglandins. And again, because of the decrease in the prostaglandin, mucus secretion and bicarbonate secretion is reduced. That again exposes the gastric mucosal cell to more acid, and they also causes back diffusion of H plus ions in the gastric mucosal cell. So these are the mechanisms by which NSAIDs causes gastric ulcer, and the patient having gastric ulcer due to NSAID, on NSAID, the drug of choice is misoprostol, that is a stable prostaglandin analog. Anaphylactic reactions. Aspirin and other NSAIDs, they produce asthma, angioneuritic edema, urticaria or rhinitis in susceptible individuals. The mechanism basically, as we are inhibiting cyclooxygenase enzyme, the other pathway, lipooxygenase pathway, increases, and there is more synthesis of leukotrienes, platelet activating factors, and that can aggravate, cause this condition, exacerbation of asthma, angioneuritic edema. Now, renal effect. NSAID causes renal injury by three mechanisms. One is the COX2 enzyme is constitutively present in the juxtaglomerular cells. By inhibiting that enzyme, there is salt and water retention. Number one. Number two, COX1 enzyme is present in the renal blood cell. They decrease the renal blood flow and the GFR is reduced. Number three, habitual use or chronic use of NSAID that causes papillary necrosis. Okay, in fact, phenacetin was the first NSAID to be introduced in the market. That has been withdrawn because of analgesic nephropathy. Although other NSAIDs are also linked for অন্যান্য NSAID তা করবে না তা নেই, করবে, যেহেতু প্রথম দেখা গেছিল ওটা সরিয়ে দেওয়া হয়েছে, কিন্তু chronic use করা হয়, analgesic nephropathy can be seen. Renal effects are not marked in the normal individual, but they are seen in the patient with hypovolemia, in the renal disease patients, in the congestive heart failure, in the cirrhotic patient, or patient receiving diuretic and antihypertensive. একটা patient on diuretic, on antihypertensive, if NSAID is used, their effects are blunted. Why? Because that is causing salt and water retention. Analgesic nephropathy. It occurs after years of analgesic use or non-steroidal anti-inflammatory drug use, particularly seen in patients receiving regular use of NSAIDs and having chronic or recurrent urinary tract infection. Now, what are the pathological lesions that are seen? Basically, papillary necrosis that is discussed earlier, followed by tubular atrophy and renal fibrosis in the advanced stage. Such individuals probably have some personality defect. একটা patient long term ধরে NSAID খেয়ে যাবে, definitely some personality defect should be there. As phenacetin was first implicated, it went into disrepute, ban করা হয়েছে. Though other analgesics are equally liable to produce these effects. Aspirin. The chemical name is acetyl salicylic acid. It is rapidly converted to salicylic acid, which is responsible for most of the actions. Now, other actions are the result of acetylation. বললাম যেটা কি acetyl radicalটা serine residue of COX enzyme কে রিপ্লেস করছে আর অ্যাসিটাইলেট করছে, তার জন্য irreversible inhibition of COX enzyme দেখা যাচ্ছে. Other actions are result of acetylation of certain macromolecules, including COX enzyme. One of the oldest analgesic anti-inflammatory drug having diverse use. Now, pharmacological action. Number one is analgesic, anti-inflammatory and antipyretic action. So, analgesic একইভাবে action করে, no sedation, subjective effects, tolerance or dependence produced. Resets hypothalamic thermostat and thus shows antipyretic action. Now, একটা রয়েছে অ্যাসপিরিনে অ্যানালজেসিক অ্যান্টিপাইরেটিক অ্যাকশন একটা ডোজে রয়েছে, লোয়ার ডোজে অ্যান্টি ইনফ্ল্যামেটরি অ্যাকশন রিকোয়ার্স হায়ার ডোজেস. ফর দি analgesic action, basically dose is 0.3 to 0.6 milligram per dose, and in case of for anti-inflammatory action, it's 3 to 6 gram per day. In addition to COX inhibition for anti-inflammatory action, there are other actions as well, like decrease in the generation of free radicals may contribute to its anti-inflammatory action. Signs of inflammation are suppressed. একটা NSAID দিলে ইনফ্লামেশন সাইনটা সাপ্রেস হতে পারে, but the ongoing disease may not be suppressed. For example, a patient of rheumatoid arthritis or a patient of acute gouty arthritis, where there is presence of inflammation, that is pain, redness, swelling, because of certain pathology. There we are decreasing the inflammation, but the disease progression is not suppressed. Gastrointestinal tract. Like other NSAIDs, aspirin shows gastric ulcerogenic effect. Now, the gastric ulcerogenic effect is because of irritation of the gastric mucosa. They inhibit chemoreceptor trigger zone, thus causing vomiting. Iron trapping. What do we mean by iron trapping? Aspirin is a weak acidic drug. Weak acidic drug means ki in the acidic medium, it is more present in non-ionized form, and in the alkaline medium it will be present in more ionized form. Non-ionized form তাড়াতাড়ি diffuse হবে across the cell membrane, ionized form তাড়াতাড়ি diffuse হবে না. Now, when aspirin is ingested orally in the gastric acidic medium, it is present as non-ionized form mostly, and what happens because of that, it is more diffusible. It diffuses into the gastric mucosa cell. There it is coming in contact with the alkaline environment, and within the gastric mucosa cell they are converted to more ionized form and they become non-diffusible. That means the aspirin particles, they are trapped within the gastric mucosa cell. That is called ion trapping. Okay. So iron trapping is again one of the mechanism of gastric toxicity. It enhances gastric toxicity. Again, aspirin particle, they causes the back diffusion of H plus ions in the gastric mucosal cell, causing increase in the gastric toxicity. They cause acute ulcer, erosive gastritis, congestion, microscopic hemorrhage. Occult blood loss in stool is increased even by a single tablet of aspirin. Now, blood. As said earlier, aspirin inhibits thromboxane A2 enzyme in the platelet by the inhibition of COX-1 enzyme. Platelet aggregation is interfered, leading to prolongation of bleeding time around 2 times the normal. This effect lasts for about a week. কেন অন্যান্য NSAID কিন্তু reversibly inhibit করছে. Aspirin is inhibiting the enzyme COX enzyme for irreversibly. So the enzyme action will return only after the newer enzyme is synthesized, and the enzyme turnover rate is around 7 days. So the effect of anti-platelet action of aspirin lasts for 7 days. While other NSAID, they are reversibly inhibiting the enzyme. So the return of enzyme activity depends on the dissociation of the drug from the enzyme. That lasts for not even a day. Long-term intake of large doses of aspirin also inhibit the clotting factor synthesis in the liver, and in that case the bleeding can be prevented by prophylactic vitamin K therapy. Now, metabolic effects of aspirin. Aspirin, they enhances cellular metabolism. Cellular metabolism বাড়লে কি হবে? Glucose utilization টা বাড়বে, and the diabetic patient, they are more predisposed to hypoglycemia. Number one effect. Number two, because of increase in cellular metabolism, respiration is enhanced, causing wash out of carbon dioxide. That is causing respiratory alkalosis. Because of this respiratory alkalosis, the bicarbonate excretion from the kidney occurs more. So there is decreased bicarbonate concentration in the body, that is causing compensatory metabolic acidosis or the compensated respiratory alkalosis is seen. ঠিক আছে? তার সঙ্গে aspirin, they increase the production of lactic acid, pyruvic acid, acetoacetic acid, that is causing uncompensated metabolic acidosis by the use of high-dose aspirin. Dehydration by the high-dose aspirin can occur due to excess water loss in urine, sweat, and hyperventilation, particularly manifested in children in salicylate poisoning, and adults can manifest in salicylate poisoning in late stage. Now, no direct effect on the heart, but because of increase in cellular metabolism, cardiac output is increased, and toxic dose can depress vasomotor center, causing fall in blood pressure. Congestive heart failure may be precipitated if cardiac output is low. Now, high-dose aspirin is also uricosuric. With the ingestion of aspirin more than 5 grams per day, it may block urate reabsorption and causes more uric acid excretion. While in the lower doses, it antagonizes the uricosuric action of probenecid. Lower dose কিন্তু uric acid excretion টা কমিয়ে দিচ্ছে, but in higher dose, it is having uricosuric action. Now, absorption from the stomach and small intestine occurs because of poor water solubility. The absorption can be increased by microfining the duct particles and by alkalinizing adding the alkali. That can increase the absorption. Alkalite basically weaker acidic drug আছে, more ionized form হবে. Higher pH favors ionization and the decreasing the diffusible form. Now, they are rapidly deacetylated in the gut wall, liver, and plasma to release salicylic acid. They are mostly plasma protein bound, 80%. Volume of distribution is low, and they are metabolized by conjugation in liver with glycine is the major pathway, and by glucuronic acid. metabolites are excreted by kidney. Now, plasma half-life is around 15 to 20 minutes, but taking the salicylic acid together, the plasma half-life increases to 3 to 5 hours. Now, when the higher doses of aspirin are taken, the metabolizing enzymes, the conjugating enzymes, they are saturated and the plasma half-life increases to 8 to 12 hours. During poisoning, when toxic doses are ingested, the plasma half-life can be as high as 30 hours. So elimination of aspirin is dose dependent. Side effect: gastric mucosal damage, peptic ulceration, hypersensitivity reactions can be seen. They are infrequent but serious, causing rashes, fixed dose eruption, angiolytic edema, asthma, anaphylactic reactions. Profuse gastric bleeding is rare but can occur. Salicylism, basically aspirin, they show CNS effect at anti-inflammatory dose, causing vertigo, tinnitus, reversible impairment of hearing and vision, excitement, hyperventilation, and electrolyte imbalance. That is together called salicylism. In children with rheumatoid arthritis, the drugs show reversible elevation of liver enzymes. Now, aspirin use in children having viral infection like influenza or the varicella, they are associated with Ray's syndrome. It's a fatal liver failure condition. Okay, it's for that reason the aspirin use has been decreased in the pediatric patient. Salt and water retention occur in dose dependent manner. Now, acute salicylate poisoning, they are more commonly seen in children, fatal dose 15 to 30 gram in adults, lower in children. Manifestation: vomiting, dehydration, electrolyte imbalance, acidotic breathing because of metabolic acidosis, hyper or hypoglycemia, petechial hemorrhage, restless, delirium, hallucination, hyperpyrexia and others. Now, death may be due to respiratory failure or cardiovascular collapse. Treatment: symptomatic and supportive, external cooling, IV fluid, sodium, potassium, bicarbonate and glucose administration as per the need, as per the requirement, and blood transfusion and vitamin K if bleeding occurs. Contraindicated in patients who are sensitive to it or having peptic ulcer disease or having bleeding tendency. In children having chicken pox or influenza because of the risk of Ray's syndrome or hepatotoxicity. Due to risk of Ray's syndrome, pediatric formulation of aspirin is prohibited in India and in United Kingdom. In chronic liver disease, the drug can precipitate hepatic necrosis. It should be avoided in diabetics for the risk of hypoglycemia, those with low cardiac reserve of frank congestive heart failure because of cardiac toxicity, and in juvenile rheumatoid arthritis. Should be stopped 1 week before elective surgery, because they increase the bleeding time because of having antiplatelet aggregate reaction that lasts for about a week. Given repeatedly during pregnancy or having low birth weight babies, they cause delayed or prolonged labor. Already পড়েছি আমরা কি NSAID use in basically in late term pregnancy that can delay labor because of inhibition of synthesis of prostaglandins. Greater chance of postpartum hemorrhage because of increase in bleeding time. Premature or closure of ductus arteriosus can be seen. Now, should be avoided by breastfeeding mothers. Their use in D6PD deficient individuals should be avoided because of risk of hemorrhage. Interaction. This aspirin, basically they are highly plasma protein bound. So the drug, when they are concurrently used with drugs having high plasma protein binding, what aspirin do? They displaces warfarin. Sulfonylurea is a hypoglycemic drug, phenytoin and methotrexate from the binding site. So their concentration is increased and their side effects are seen. Okay. Aspirin and at analgesic dose inhibit tubular secretion of uric acid and antagonizes probenecid. Analgesic dose probenecid action কি রয়েছে? Probenecid basically uricosilic drug. it increases the excretion of uric acid. Now aspirin basically at analgesic dose, lower dose, they inhibit the action of probenecid. They inhibit uric acid excretion. But again, aspirin at high dose, more than 5 gram per day, they basically increase the uric acid excretion. Opposite things are seen. Tubular secretion of methotrexate is also interfered. Aspirin blunts the diuretic action of thiazide, furosemide. They reduces potassium conserving action of spironolactone. Uses as analgesic, as antipyretic. They are effective in fever of any origin, but definitely paracetamol is more preferred because they are more safer. Acute rheumatic fever, aspirin is a drug of choice in all cases. Rheumatoid arthritis, osteoarthritis, definitely paracetamol is a drug of choice in osteoarthritic patients. In post-myocardial infarction and in post-stroke patient, low-dose aspirin is preferred because of the antiplatelet action. Prevention of preeclampsia, it is seen that low-dose aspirin given to a mother uh, from the 12th week pregnancy till childbirth, that decreases the incidence of preeclampsia and eclampsia. Other conditions, familial colonic polyposis. The use of aspirin there, they decrease the risk of colon cancer. It has been seen. Prevention of colon cancer. To prevent flushing, attending nicotinic acid ingestion. Now, these are all about the aspirin. Coming to the propionic acid derivative, ibuprofen was the first member of this group introduced. Okay, all have similar, কি আছে ibuprofen আছে, naproxen আছে, all have similar pharmacodynamic properties, but differ in their potency of analgesic and anti-inflammatory action. All members inhibit prostaglandin synthesis. They inhibit platelet aggregation, but is shorter lasting with ibuprofen, longer lasting with naproxen. Adverse effect, better tolerated than aspirin. Aspirin is more ulcerogenic. They are better tolerated. Gastric discomfort, nausea and vomiting still is the most common side effect with them. CNS side effects are also seen: headache, vertigo, tinnitus, rashes, itching, hypersensitivity reaction can be seen. They can precipitate aspirin-induced asthma. Fluid retention is less marked. They are contraindicated in pregnancy and peptic ulcer patients. Well absorbed orally, highly plasma protein bound, largely metabolized in liver and excreted in urine and bile. Displacement reactions are not clinically significant here. Use of anticoagulants should be avoided because of the risk of increased bleeding, and they are likely to decrease diuretic and antihypertensive response. They are used as analgesic and antipyretic. Particularly, they are effective in dysmenorrhea patients. They are available as over-the-counter drug, widely used in rheumatoid arthritis, osteoarthritis, or any musculoskeletal pain, especially where pain is more prominent than inflammation. They are weaker anti-inflammatory drugs. Indicated in soft tissue injury and others. Ibuprofen, it is rated as the safest traditional non-steroidal anti-inflammatory drug as rated by the spontaneous ADR reporting system in United Kingdom. Now, they have got, as said in the propionic acid derivative, they are not suitable for acute gout or other similar conditions. Naproxen, they have got more stronger anti-inflammatory action compared to ibuprofen. Gastric bleeding is more common. They carry lower thrombotic risk. Ketoprofen, they have got additional action of stabilizing lysosomes and to inhibit lipoxygenase pathway. They have got anti-inflammatory action similar to ibuprofen and side effects are more. Flurbiprofen, they have got additional mechanism of anti-inflammatory action. They are used also in ocular inflammatory conditions. Mefenamic acid, analgesic, antipyretic and weaker anti-inflammatory action. Diarrhea is the most common side effect. Hemolytic anemia is rare but serious. Piroxicum, that comes under enolic acid derivative. They have got anti-inflammatory potency similar to indomethacin. Indomethacin has got the very powerful anti-inflammatory action with good analgesic and antibiotic action. They are non-selective inhibitor of COX. They are like other NSAIDs, they are rapidly and completely absorbed orally, highly plasma protein bound. Gastric side effects are more than the ibuprofen. Used as long-term anti-inflammatory drug in rheumatoid arthritis, osteoarthritis, but not the drug of choice there. Ketorolac, they are more commonly used in the post-operative pain. It has equal efficacy of morphine in the post-operative pain. They are rapidly absorbed by oral and IM administration, highly plasma protein bound, metabolized in liver, excreted in urine. Now, they are not recommended for use more than 5 days because of gastric toxicity and renal toxicity. Topical ketorolac is also available for for inflammatory conditions in eye. Indomethacin. Indomethacin, they are highly potent inhibitor of prostaglandin synthesis. They have got additional activity of suppressing neutrophil. In toxic doses, it uncouples oxidative phosphorylation. They have got high incidence of gastrointestinal toxicity and CNS toxicity. It's a reserved drug in conditions requiring potent anti-inflammatory action where other traditional NSAIDs are not capable. Like ankylosing spondylitis, acute exacerbation of destructive arthritis, psoriatic arthritis, acute gout or rheumatoid arthritis. Malignancy associated fever not responding to other antipyretic may respond to this drug. অতটা anti-inflammatory action এতে আসে. Is the most common drug used for medical closure of patent ductus arteriosus. And the other use Bartter syndrome, respond dramatically with indomethacin. Nabumeton is a prodrug. The active form is 6-methoxy-naphthyl acetic acid. It has got analgesic, anti-inflammatory and antibiotic action, lower incidence of gastric erosion, ulcers and bleeding. Preferential COX-2 inhibitors. COX-1 থেকে বেশি COX-2 ইনহিবিট করছে। তাতে অ্যাডভান্টেজটা কি? অ্যাডভান্টেজ রয়েছে gastric cells, gastric toxicity is shown because of inhibition of COX-1 enzyme in the gastric mucosal cell. Now, as they are inhibiting COX-2 preferentially, the gastric toxicity relation. Nimesulide is a relatively weak inhibitor of prostaglandin, but they have got good anti-inflammatory action because they reduce generation of superoxide and neutrophils, inhibition of PAF synthesis, and they TNF alpha release. They have got free radical scavenging action and inhibition of metalloproteinase activity in the cartilage. These are some of the mechanisms by which it is showing anti-inflammatory action, although the COX inhibiting capability is low with nimesulide. Now, most gastric tolerability is better, but problem with nimesulide is that it has been associated with the instances of fulminant hepatic failure. So, in fact, this drug is banned in US FDA, by US FDA. Most asthmatics who basically show bronchospasm with aspirin or does not tolerate it, nimesulide can be an option. It does not cross react with nimesulide. Diclofenac, they do not have the cardioprotective action as shown by the low dose aspirin. Neutrophil chemotaxis and superoxide production are reduced. Good tissue, particularly synovial fluid. The concentration attained by diclofenac in synovial fluid lasts 3 times longer than the traditional NSAID. So they are more effective in joint conditions, joint pains. Now, they increase the risk of heart attack and stroke. Reversible elevation of transaminase, renal blood flow and GFR may be reduced. Most extensively used NSAID. Okay. Aceclofenac has got additional advantage of chondroprotective action. They increase the synthesis of glycosaminoglycan. Meloxicam, the COX-2 is to COX-1 selectivity 10, Gastric side effects milder. Etodolac is a newer indole acetic acid NSAID. They are moderately COX-2 selective. Selective COX-2 inhibitors. Selective মানে maximally COX-2 এনজাইমটা ইনহিবিট করছে। তাতে অ্যাডভান্টেজটা কি আছে? অ্যাডভান্টেজটা হচ্ছে গ্যাস্ট্রিক টক্সিসিটি লোয়ার। But the problem with these drugs are they increase the incidence of cardiovascular event. Why? This is because the traditional NSAID, they were blocking the synthesis of thromboxane A2 and they were showing anti-platelet action. Now, these were because of the inhibition of the COX-1 enzyme in the platelet. They are preferentially or they are selectively blocking COX-2. So they have got no action on the platelet. But they are inhibiting the prostacyclin synthesis from the endothelial cells because of COX-2 inhibition. And thus they are pro-aggregated and they are increasing the chance of heart attack and brain strokes. Cause less gastric mucosal damage, occurrence of peptic ulcer and ulcer bleed definitely lower, but lacks cardioprotective property of aspirin. Now currently 3 coxibs, that is selective COX-2 inhibitors, are available: celecoxib, etoricoxib and parecoxib. Rafecoxib and valdecoxib, they have been withdrawn from the market because of increased cardiovascular risk. But they may also be associated, but they are still there. Should be used in patients at high risk of peptic ulcer, only in patients at high risk of peptic ulcer, ulcer bleed or perforation. Should be administered in the lowest possible dose, should be given for the shortest period. Should be avoided in patients with ischemic heart disease, with heart failure, cerebrovascular disease, because of the chance of cerebrovascular events. COX-2 selectivity is modest, 10 times, low ulcerogenic potential. Is for celecoxib. Tolerability is better. They are approved for use in rheumatoid arthritis and osteoarthritis. Etoricoxib, they have got highest COX-2 selectivity. Now, they basically they do not affect the platelet function or damage the gastric mucosa. They should be used as per the condition, although the drug still is not associated with increased cardiovascular event, but they should be used as per the conditions set up for COX-2 inhibitors. That means for shortest period and in those patients at high risk of peptic ulcer disease and they are not having any cardiovascular disease. Side effects are dyspepsia, abdominal pain, fetal edema, rise in BP. Parecoxib is a prodrug of valdecoxib used in post-operative or similar short-term pain. Risk of serious side effects, skin rash is there. So the drug should be withdrawn when, even if the first appearance of rash is there. Paracetamol or acetaminophen. Now is the deacetylated active metabolite of phenacetin. They have got good antipyretic action, good analgesic action, but they have got minimal anti-inflammatory action. They inhibit COX enzyme anti-inflammatory action compared to other NSAIDs that cannot nahi ekhetre, because they are unable to inhibit the cyclooxygenase enzyme in presence of peroxide, which is generated at the site of inflammation. Inflammation জায়গায় ফ্রি র্যাডিক্যাল গুলো তৈরি হয়, তার মধ্যে একটা যে peroxide, peroxide presence এ cyclooxygenase enzyme প্যারাসিটামল ইনহিবিট করতে পারে না. That's why they are very weak anti-inflammatory drug. But they have got potent analgesia action, they have got potent antipyretic action. They also inhibit COX-3 enzyme in the brain and thus they have got good antipyretic action compared to other NSAIDs. The gastric irritation is insignificant, they does not affect platelet function and they are not uricosuric unlike aspirin. When absorbed orally, metabolism occurs by conjugation and with glucuronic acid sulfate, mainly by glucuronic acid. Conjugates are excreted in urine. Adverse effect: at analgesic dose, paracetamol is safest and it's worldwide used. Safest and well tolerated. Over the counter drug, first choice of drug for osteoarthritic patients. It is not associated with Ray's syndrome, so they can be safely used in children. Now, acute paracetamol poisoning. It occurs in particularly in children when toxic dose of paracetamol is taken. What the toxic dose is more than 150 milligram per kg or more than 10 gram in adults. Now, serious toxicity can occur or fatality can be seen with more than 250 milligram per kg of drug ingested. Now, what is seen? Nausea, vomiting, abdominal pain, liver tenderness. As the time passes, by 12 to 18 hours, there is hepatic necrosis, centrilobular hepatic necrosis, and renal tubular atrophy, necrosis. Hypoglycemia may occur, and the patient with time can progress to coma. Jaundice start after 2 days, and the cause of death is fulminant hepatic failure. Now, why they are occurring? Paracetamol is metabolized in the liver. One of the minor metabolite is NABQI. What is that? N-acetyl P-benzoquinone is a minor metabolite. Metabolized by this NABQI is further metabolized by glucuronide conjugation in liver. Now, when the large amount of paracetamol is ingested, the more NABQI is formed. What happens? The glucuronide in the liver, they get saturated. So, more NABQI is non-metabolized in paracetamol toxicity. And this NABQI is a reactive compound. They bind to the proteins in the liver cells and in the renal tubular cells, and thus they are causing necrosis. NABQI is a highly reactive arylating minor metabolite of paracetamol, detoxified by glutathione conjugation. When large amount of is ingested, glucuronide conjugation capability saturated, more minor metabolite is there in the body. They are binding with the proteins in the liver cells and the renal cells, renal tubular cells, causing toxicity. Even in chronic alcoholic, even 5 gram of paracetamol can show toxicity, because alcoholism, they induce CYP2E1 enzyme. This CYP2E1 enzyme causes more formation of NABQI. একটা প্যারাসিটামল থেকে NABQI করতে CYP2E1 এনজাইমটা কাজ করছে। যখন more of CYP2E1 enzyme is there because of chronic alcoholic effect, so more NABQI is formed. In chronic alcoholics, even lower dose of paracetamol can cause toxicity. Why? Alcoholism, that is stimulating the synthesis of CYP2E1 enzyme, which is causing more generation of the NABQI, and that is enhancing paracetamol toxicity. Now, because of this hepatotoxicity, paracetamol is not recommended for premature infants. The treatment of the acute paracetamol poisoning. General supportive measures like gastric lavage, they decrease the absorption of the paracetamol from the stomach. Activated charcoal, gastric lavage, that removes the paracetamol in the stomach. Activated charcoal, that decrease the absorption of the paracetamol in the stomach, and others. N-acetylcysteine. N-acetylcysteine is the antidote, specific antidote for paracetamol poisoning. What is that causing? They are replenishing the glutathione stores in the liver. Earlier the treatment started, better the result. এই যে পেশেন্ট প্যারাসিটামলটা খেলো হাই ডোজ, আর ট্রিটমেন্টটা স্টার্ট করলাম, এই যে ইন্টারভালটা ভেরি ইম্পর্টেন্ট। যতটা দের হবে ততটা কিন্তু প্রগনোসিস খারাপ। So earlier the treatment started, better is the result. Practically ineffective if started 16 hours post ingestion. Topical NSAID. Topical NSAID, basically they are used in localized painful conditions like osteoarthritis, sprain, sport injuries, tenosynovitis and others. Because they are used topically, the systemic side effects, gastric toxicity are lesser. Doubts over actual efficacy, because thus they are being used topically, often used in addition to other NSAIDs. একটা oral NSAID এর সঙ্গে commonly topical NSAID টা apply করা হয়। So guidelines of several professional bodies recommend topical NSAID only in mild to moderate case of osteoarthritis pain of hands and knees. একটা একটা NSAID কোন কোন কন্ডিশনে কোন কোন NSAID ইউজ করব তার উপরেও কিন্তু বিভিন্ন ক্রাইটেরিয়া রয়েছে। একটা পেশেন্ট পেইন নিয়ে আসছে কিন্তু ইনফ্ল্যামেশনটা কম, এখানে কিন্তু আমরা প্যারাসিটামলটা প্রিফার করি। ওয়াই? বিকজ অফ lower toxicity. Paracetamol is the safest drug among the NSAIDs available. Problem with paracetamol is that they have got very weak anti-inflammatory action. যেখানে পেনের সঙ্গে ইনফ্ল্যামেশনও রয়েছে সেখানে প্যারাসিটামল খুব ভালো কাজ করবে না। তো পেশেন্ট হ্যাভিং musculoskeletal pain or any sprain, osteoarthritic pain, there we prefer paracetamol. Okay. In case of pain with inflammation, একটা আসছে সেখানে কিন্তু আমরা প্রিফার করছি ডাইক্লোফেনাক। বেসিক্যালি যারা they have got potent anti-inflammatory actions, naproxen, diclofenac, indomethacin and others. একটা পেশেন্ট হ্যাভিং গ্যাস্ট্রিক আলসার ডিজিজ উইথ পেইন, সেখানে কিন্তু we prefer selective COX-2 inhibitors or paracetamol because they have got lesser gastric toxicity. একটা পেশেন্ট with ischemic heart disease, with hypertension, those having high risk of cardiovascular event, we should avoid selective COX-2 inhibitors because of the high risk of cardiovascular event. In case of pregnancy, paracetamol is the safest drug, and the second safer drug is low dose aspirin. ঠিক আছে? তো এইগুলো বিভিন্ন ক্রাইটেরিয়া রয়েছে ফর দ্য চুজ অফ non-steroidal anti-inflammatory drug in patients. Now coming to the combination of NSAIDs, many drugs are available in the market where two NSAIDs are combined, like paracetamol with aspirin or paracetamol with diclofenac. Now their combination is maybe additive, but they are not super additive. Additive or super additive মানে কি? দুটো drug A and B combine করছি, so one is the effect is equal to A plus B, and one is the effect is equal to less than A plus B, and one is the effect is more than A plus B. যখন দুটো drug combine করছি, if the effect is more than each of the drug, that is called super additive action. If the drug effect is equal to the combination of drug, then they have got just additive action. So the combination of NSAID, they have got additive action, and the ceiling effect is there. Why the ceiling effect? Their mechanism of action is similar. ওরা কিভাবে কাজ করছে? বিকজ অফ ইনহিবিশন অফ সাইক্লোঅক্সিডেজ এনজাইম। তো একটা জায়গায় এসে স্যাচুরেট তো হবেই, so they have got ceiling effect. So basically efficacy or safety with the combination compound is not justified. কখনো কখনো NSAID এর সঙ্গে কিন্তু কোডিন opioid like drugs ও কম্বাইন করা হয়, like codeine with paracetamol. Their combination are additive, but they do not show ceiling effect. কেন কি? they act by different mechanism. ঠিক আছে? and they can be needed in certain conditions where NSAID are not effective.